So next we'd like to have our medical directors present to you our plan for population health, and Dr. Larry Blosser will present initially, and he'll be followed by Dr. Don Deep.
All right, well, welcome everybody. Let me echo Bill's thanks for coming out on a summer night, and thank you to our partners who are helping put tonight on. Navigating the road to population health. Thought I'd talk to you a little bit about why this whole thing came about. A couple of our staff were talking about population health, and one of them, who I think is really a pretty sharp person, kind of said, well, I've heard a lot about population health, and I've heard a lot about this and that and HCC coding and RAF scores, but I don't really understand population health. So we sat down and tried to kind of diagram it out, and Judy and Rob have come up with this great presentation. You're going to see all the work that they've done. And this is really a 30,000-foot view of population health. We're not going to get into the minutia and the nitty-gritty, but we're going to kind of talk about all the different parts of population health as they relate to what we're doing in COPC. Because if some people who are pretty intimately associated with population health don't understand how all the pieces of the puzzle fit together, you might not either. So hopefully at the end of tonight, you'll come away with a better understanding of what population health is, at least in our view at COPC, and how we're planning on walking down the road to population health management. So COPC's journey to population health management. Because medicine's changing. It's not the same world. You just heard from Jeff, as he so adequately teed that up. We're in a changing environment. Fee-for-service is not the long-term solution. And so population health for us is where we think we're headed, and we're headed down that road with Dorothy. What's our end game? Building relationships throughout the continuum of care to impact better outcomes. And I think this will become evident. We'll come back to this kind of at the end, and I think maybe we'll be able to put it all together for you then. Triple aim of the Affordable Care Act. It's improving patient satisfaction by improving patient experience. It's increasing quality by improving the health of populations. And its value. It's lowering the per capita cost for care. And as we move into population health, these are the three goals that we have for our patients at COPC. What's population health management? Healthcare definition. Health outcomes of a group of individuals, including the distribution of such outcomes within the group. Anybody else feel like that? I read this to my wife 8 times, and she still kind of had that blank look on her face after the 8th one. Well, we have our own definition. And if you read or if you listen to talk about population health, you'll hear lots of different definitions out there in the healthcare environment. But this is ours. Population health management is assuming both clinical and financial responsibility for the health care of a population. Clinical responsibilities include well care and prevention, as well as treatment of acute and chronic illnesses. So that's kind of what we've been doing already. We're kind of good at this. Medicare Advantage. You probably have all heard that we've been talking to you about we want you to do certain things with Medicare Advantage patients, and that's because Medicare Advantage is our first step down the road for population health management. Why did we choose it? Why choose Medicare Advantage plans? Well, we're able to participate in a shared savings plan with Medicare Advantage plans. That means that we finally get paid for the stuff that doesn't happen, the stuff that primary care is pretty good at, taking good preventive care of people and making sure that they don't experience certain health outcomes which are costly and unfortunate for patients. The other reason we're involved with Medicare Advantage plans is that the Medicare Advantage plans are risk adjusted. We're going to talk about that again here in a little bit when we talk about HCC coding, but that means that the payment for patients is dependent upon how sick they are. Medicare Advantage plans also provide yearly wellness exams for their patients. And these wellness exams offer us the opportunity to sit down and really review with patients all of the issues that affect their health. It allows us to accurately look at what disease states and conditions they have. It allows us to plan how we're going to take care of those and prevent possible negative outcomes down the road. There's no copay and no charge to the patient, so this is a nice thing for them. And the Medicare Advantage plans need some information back from us from these things. Care management, not managed care. I heard Dr. Wolf say a couple of weeks ago that, part of the difference between Medicare patients and commercial patients is that Medicare patients are going to stay with you forever. Unlike commercial patients who might change plans, move on to something else, they're on to a different doctor, these patients are pretty much connected to you forever. And this is where I think you go back to that old adage of an ounce of prevention is worth a pound of cure. If we take care of these patients now, we're going to prevent some downstream problems. And you can't win by withholding care. You need to provide the right care right now so that you don't experience negative consequences down the road. Traditional Medicare versus Medicare Advantage. Put this up really so that you can kind of think a little bit if it's at the front desk, how do I identify Medicare Advantage patients? Well, their card looks a little bit different. That's one way. We talk about what are the benefits for the different plans, and you probably all are pretty familiar with what standard Medicare benefits are. Under the Medicare Advantage plan, private insurance companies contract with Medicare to provide the services. So you'll see Medigold or Aetna, Humana, and the benefits run through these private insurance plans, really not through Medicare. There are differences between the plans, and I'm really not going to go into that too much. Medical management through the Continuum of Care. So you can see all the signposts. This is all the stuff that you might hear us talking about. HCC and RAF scores, HEDIS measures, risk stratification, care coordination, patient-centered medical home, same-day center, and on and on and on. So what we're going to do is break this down a little bit and hopefully give you a little bit of what's going on under each one of these headings. It's pretty cool, huh? HCC and RAF scores. HCC is hierarchical condition categories. And if you're a provider, you know that we've been asking you to work really hard to make sure that we have coded and identified all the HCC categories and conditions for a patient. If you're some of the office staff, you may have seen, stuff coming in that you needed to give to the doctor to make sure that they were up to date on who they were going to see and some suggestions that were coming through. But for our plan and for plans like this to succeed, you have to really do a good job with these, getting these HCC categories right. This is a quality initiative because we're identifying how sick a patient is. And as Jeff said, we need to be able to stratify the patients on that pyramid and know who fits in the top bucket, who's in the middle bucket, who's in the bottom bucket, because that's how we're going to effectively take care of those patients, by identifying where they fit and what their needs are. This is going to be physician-led because these codes have to be applied by the physician evaluating the patient. They have to make an assessment, and they have to have a plan to deal with these. Clinical excellence and differential diagnosis. Part of what goes into this is that we can all say things in different ways. There are some diagnosis codes that don't risk adjust, but if you utilize and find an HCC code, that will risk adjust the severity of illness for the patient. So sometimes you'll get suggestions from our HCC coding committee. If you're a physician that says, hey, I see you've coded this, you might consider using a different code. Probably means the same thing, but your first code doesn't risk adjust, your second code does. entire healthcare team. This is a team game. You know, we've moved away from the time when one doctor took care of one patient. We're now in the day when, as a team, we take care of a population of people to try and achieve outcomes. So we're going to rely on a lot of different people to help us with this HCC coding. I mentioned coding committee. We have a committee of 8 or 9 physicians. Those physicians are given, they're assigned to specific practices, and they're given the schedule for all the providers in those practices about a week or 2 in advance. And they're given the schedule for the Medicare Advantage patients. They go through those charts and they look for codes that haven't been coded recently to say, hey, I saw 2 years ago you coded that there was a foot amputation, but you didn't code it last year. You probably ought to code it because we don't think that foot grew back. But Medicare doesn't allow the code to roll over from year to year. These codes have to be recoded every year to be valid. So those doctors are going through, they're sending notes or sometimes through the Jelly Bean or sometimes emails to physicians. If you're getting those, that's because they've spent some time looking through the chart, looking back at old diagnoses, maybe some things that you haven't seen. There may be a CT scan that showed some calcification in the aorta, and you haven't coded for vascular disease. And that's a valid code, and that increases the risk adjustment for that patient. It's not a coding game. We're not trying to play a game. We're just trying to really code what is really there. And we're going to talk here about STAR quality initiatives that are associated with these HCC categories. STAR ratings for Medicare Advantage plans. You may hear us talking about that. Medicare uses information from patient satisfaction surveys as well as from plan data and provider data to come up with a STAR rating for the plans. It's kind of like the Michelin guide. 5 stars is really good. 1 star is not so good. So this allows consumers to kind of look at the plans and make an assessment of what might be a better value for me. If plan costs are about the same, I think I'll go with a 5-star plan. Ratings are updated each year and they change from year to year. And a patient can switch to a 5-star Medicare plan throughout the year. They don't have to wait for open enrollment. And this is important to us because we're working to try to improve the STAR ratings for all of the plans that we partner with. It's to our benefit, it's to their benefit. It's a differentiator for health plans, and there are significant financial drivers. One of the plans that we work with has moved up in STAR ratings this year so that the anticipated reduction in Medicare payment to them is offset by the bonus they're going to receive. So we've done some work there. We've improved the STAR rating, but it's really to help the health of that plan for the patients that we're partnering with them on. HEDIS and quality measures, we're going to talk about that in a minute. And this is a national initiative, so all Medicare Advantage plans have this STAR rating. HEDIS measures and closing care gaps. You probably hear from time to time that, hey, there's some care gaps on your patient. We're going to talk about that in a minute. And what's the importance of that? Why do I care about that? HEDIS measures are really evaluations of what's happening within a plan, how those patients are being cared for, and we're looking at care gaps. So I'm going to give you an example of a HEDIS measure, and we'll talk about what the care gap is. So in this HEDIS measure, we're looking at hemoglobin A1C screening for diabetics. And there are a couple of components. There's a hemoglobin A1C testing. That's just a yes or no. Was it done? Yes or no. That's just really a process measure. And then hemoglobin A1C, poor control greater than 9%. They want to know what percentage of the patients have that. So that's really a quality performance measure. And that all gets rolled up into a number over on the left-hand side, and you can see that You know, for some plans, a one-star plan, less than 48% of the folks have received an A1C and are below 9. So 48%, that means that there's a 52% opportunity. That's the care gap. Those are the number of patients that didn't actually get done what we think they should have done. As Jeff said, you know, what percentage of diabetics have had all 5 of the indicators done this year? So you can see that we have an ability to help the plans change their star ratings. How are we doing that? We're doing that with our quality department nurses. They are working with the plans and the offices to identify where these care gaps are, and they're sending notices to the physicians, to the providers, to say, you know, you've got this patient who hasn't had an A1C done this year, or this patient that hasn't had another metric done. So we're not really trying to harass you with that. We're just trying to provide you the information that's actionable so that you know what patients need to be looked at and taken care of. So these are our quality nurses, and you can see the plans that they're associated with. Risk stratification. So how do we put people in those high risk, medium risk, and low risk buckets? We have done it by asking physicians to try to identify patients that are really sick. We have done it by looking at HCC codes and looking at who are the ones with the highest risk adjustment factors. And we've taken that top group to look at more closely. But we're going to make it a little bit easier. We're implementing a point of care tool which will work with our electronic health record to help us to identify a number of different things. So eventually, this is going to come up to the window when a provider is caring for a patient, and you're going to be able to see, first of all, care gaps. You know, what's been taken care of this year and what you still have to look at, and HCC codes. And it will help us to determine what codes were done last year, what codes were done this year, and what codes have not been coded this year. And then the question is it still valid? Should it still be coded? This may also have some intuitive features to it, like you've prescribed a medicine for COPD, but you haven't coded COPD. It may give you some warnings and help you to find some codes that you may have treated but have not coded correctly. So the HCC program is essential for risk stratification, and this tool, this point of care tool, is going to help us to maximize that HCC coding. I think you've seen this pyramid already. So high-risk patients, 5% of the patients, and they spend about half the healthcare dollar. The middle group we're calling rising risk patients, because these are folks that we are worried are going to end up here and be high-risk patients. So we've got one strategy for high risk. We've got another strategy for the rising risk patients to try and make sure that we've adequately cared for them. High-risk patients and care coordinators. We have piloted a project with care coordinators, which has been successful enough that we're now moving that to the whole enterprise. We have recently hired 3 more care coordinators, and we have 1 spot that we're going to fill yet, so we will eventually have 10, and hopefully that's enough to service the needs of all the offices with care coordination. I got to remind you that the care coordinators, it's a nice service to have, but it's really for our Medicare Advantage patients. That's who we really are advocating the use of this for, and that's where the funding comes from. So these care coordinators can help, after we identify the high-risk patients, to wrap some services around them and make sure that we're doing the best we can for them. So they can be identified or patients can be identified for care coordination in a number of ways. It may be that a patient's in the hospital and we decide that, hey, just by virtue of having been hospitalized, you're a high-risk patient, or through the HCC coding. The care coordinators will help us to develop individualized care plans, help work in community resources and services that the patients may benefit from, and be active in engaging patients in follow-up. Yep. How do we take care of high-risk patients? We're going to bubble wrap the top 5% who spend 50% of the healthcare dollar. Now, I certainly hope when you're taking care of one of these high-risk Medicare patients that you're as happy as this guy, because he looks like he's having a good time. If you don't have them yet, we have some handouts that will help to explain the care coordination program to patients. I think sometimes they're a little reluctant. They're not quite sure. They've never had this done before. So they really don't know, do I want to do this or not? This will help a little bit. So here are our current 6 care coordinators. And as I said, 3 more began training this week, and we hope to have 1 more in the near future. Another tool we have to help take care of these high-risk patients is Dr. Blosser. This is our home care physician. She does not have a practice of her own, but she is here to help take care of Medicare Advantage patients who may be homebound, who are unable to get into the office. They have some needs. She's willing to go out and see them, implement a plan of care, try to get them back on their feet, and then return them to the practice when they're able to get back out of the home and get back to an office for a visit. I talked with her today, and she tells me that she's probably worked with 15 different offices so far and maybe 20 different physicians. We have kind of reviewed the cases that she's been doing, and in the short time she's been working, she's pretty sure that she can clearly identify at least 13 patients that she prevented a hospitalization on. And you know, when we're in a shared savings plan, preventing that hospitalization is really a big deal, because that's an expensive outlay for folks. Patient-centered medical home. You know, everybody's done some work about becoming a patient-centered medical home, and I think we should all feel really proud and really thankful that you helped us with that. But what this has done is it's taught us something about how to manage patients with certain disease states. So, as Dr. Wolf said, this is a building permit, and we are building. We are building how we're going to care for that rising risk group of people from our experience in patient-centered medical homes. There's a lot of overlap. Patient-centered medical home on the left, the rising risk. This is going to be team-based, just like we are in patient-centered medical home. Access is key. You know, if you've got a patient, Medicare Advantage patient, and they need to see you, it probably means they need to see you today or tomorrow, not 2 weeks from now. We're going to be able to use structured data in the EHR, and we're going to use PCMH techniques to help us identify the rising risk population, to help identify that middle group that we're worried about becoming high risk. We're using care coordination, and we're going to use analytics to help see, are we really doing what we think we're doing? So with the patient-centered medical home, with this being a team sport, we ask you all here tonight kind of as a team. It was intentional that we asked for a physician champion, a site rep, and a clinical lead. You all are the messengers back to your sites to talk about population health and to explain and engage around patient-centered medical home, especially for that rising risk group. We are going to, at first, focus on 2 entities in the rising risk group. We're going to look at diabetics with a hemoglobin A1C over 9, and we're going to look at diabetic smokers, because these are two disease states that pose a lot of potential for complications, and we think that we can prevent those by intervening. That program is kind of up and getting started. We've got a couple of sites that we've been piloting this idea with, and we'll probably have kind of the outcomes from that in the very near future to share with you. Same-day centers. We're here when your physician is not. COPC version of an urgent care, but without the high cost. And the great part about our same-day centers is they're connected to us within the same electronic health record. If for some reason you can't see a patient and it's a Medicare Advantage patient, and you know, that old temptation of, well, just send them to the ER, well, we're in a shared savings program. That's probably not the right answer. If the right answer is, yeah, I think maybe they could go to the same-day center and be evaluated by the doctors there, that's probably the right answer. If you can't provide the care, the same-day center could. We've talked with the physicians at the same-day center about our vision of population health. They understand it. They work in the same record, and they're going to be on board with us. If you send them to the ER, that's a bad outcome in shared savings, because those folks are going to get admitted. Gives us the ability to control and manage our own patients within our own walls of our company. Low cost, high quality, and integrated same-day care. That's what we're really looking for. So this is brochure on the same-day center. If you haven't seen these, or if you need some, I think we have some of those as well.
A couple of take-homes from my 30 minutes. No, I'm not going to do 30 minutes. I'm a couple of quick take-homes as I run through my stuff. One, and it was brought up by Jeff and by Bill and by Larry. If you are at home and you are hearing about healthcare is going to change, or you're reading about it, it is changing and you are involved in it. It frustrates me sometimes when I keep hearing people in COPC or Ohio Health or Mount Carmel talk about healthcare is going to change. It's changing, and this is it. So you don't need to wait for anything else. So this is it. So we are on the, I was talking to Mary today, and she said one of the frustrating things is people want to Google what we're doing to find out how to do it. It doesn't come up. But that's okay. That means that we're doing it. So when you read articles about how the government's going to change things, just feel like, yeah, we're trying to change things to see how we do. Observation care for what we do now, it's really kind of, it's a way we can streamline patients in an inpatient setting and hopefully manage them effectively and efficiently and quickly. We can kind of bring them into an observation unit or under observation status and determine whether they need to stay in the hospital or not in a kind of a more controlled setting. We have an observation unit at Riverside that we exclusively run that's quite large, but it's a good venue because it's the biggest hospital in the city. It lets us get a lot of our MA patients and all of our other COPC patients in to effectively manage them. We have observation services obviously with us rounding at St. Anne's now, and all this information is available in our packet. You can see Nilesh's contact information. Heidi is our transition of care nurse at St. Anne's, who's over there, who most people know. We round at Dublin. We have a transition of care nurse and a doc there all the time. And we have Kelly Warrens is over, yep, there she is. She has been the transition of care nurse at Mount Carmel East. And again, this contact information is all the information for everybody. The CDUs. So this is take-home point number 2. This is new. They're doing them some places in the country, but they're not doing them around here, right, Bill? That we know of. So what is a CDU? What is a clinical decision unit? When the patient doesn't quite need to be in the hospital, but they still need an intensive level of service, you don't think they can get it at home. We are opening CDUs in 2 facilities in the city, at Whetstone and at First Community Village with our partners. We are trying to get the patients better care at less cost. Columbus does a really good job of marketing, the hospitals in Columbus do a really good job of marketing their hospitals to people. And people in Columbus feel like it's great to go to the hospital. It's a good thing to go to the hospital. The hospitals here are not marketed as high-end, come only if you're sick, right? They're marketed to make people feel very comfortable to come, which is good for the hospitals, but bad stuff happens in the hospitals. And they're expensive, and we do unnecessary things. So not everybody that needs to be in the hospital, that's in the hospital, doesn't need to be there. There are a lot of patients that can get the same level of care, if not better quality of care, in a much more appropriate environment. We're trying that with the CDUs. So who could possibly go to a CDU? Mild exacerbations of chronic conditions is a good way to think of things. We're not looking to do a lot of diagnostic tests at CDU. So if you have acute abdominal pain, acute chest pain, we're not looking to bring you in to rule you out of stuff. If you need IV fluids, if you need IV antibiotics for something, those are good cases of people that could go to a CDU. Most people, when I bring this up, ask, well, where are these people going to come from? Do you want them to come from our office? And the answer is yes. Eventually, we really want these people to come from offices when they're seen by a doc or the same day center. We may even get to a point where we're able to get people directly from an emergency department into a CDU. But again, the hospitals have done a great job of making people feel like they need to come into the hospital and feel very comfortable there. So when we bring up emergency department to CDU, everybody kind of gets a little icky. Thinks, well, shouldn't I come into the hospital first? We understand that that's a sensitive issue. So observation care becomes important, and it's going to be a work in progress. But we do want people to understand that eventually we want people to come from offices directly into a CDU. Dr. Rich Gummer is working with me and Tom as the lead physician on our CDU initiatives. Their contact information for 24/7 is there, and that information is in the books in the back, as well as some other photos. This is the handout for patients that kind of describes our inpatient services and the CDUs. And there's this picture and this picture are the unit at First Community Village. And they had an open house last week or the week before. And I don't know how many people got to go. But one of the reasons that the open house was important, especially for the inpatient docs, and we had about 35 of our partners go, was that we had to be comfortable looking at patients in the eye and saying, this is a good place to go. This may not be considered your typical nursing home or your typical SNF. And it's not. It is, it's clean. It's gorgeous. The rooms are private. Services are top notch. So we were very comfortable walking out of there saying, this is going to work. This is going to be comfortable when Kristen is our transition to care nurse in the back, who is going to exclusively work at the CDUs. When she looks at patients in the eyes in the hospital, and she talks to the office people about whether the CDUs are a good idea and the patient's going to get better care there than they will in the hospital, we needed to feel honest with ourselves and saying yes. So this is a cost savings example slide of what happens compared to when you're in the hospital with a DRG with conditions like a headache or cellulitis versus if you're in the CDU. And you can see that there's significant savings for patients when they go to a CDU for the hospital. Now, right away, people might also think, and they ask us, the hospital people might ask us, well, aren't the hospitals going to get mad if you take people out of the hospital? And what I would tell you is the hospitals that we work at, the answer is no. These aren't really the people the hospital want in the hospital. They want sicker people, higher end people that they can do tertiary and quaternary care procedures on. And the people also ask us, aren't you going to be mad if you don't have hospitalized patients? And what I would tell you is we have enough. We're seeing, about 400 patients a day. We have enough. These are the people. This is a small drop of stuff that we're trying to change healthcare for the better. So this is a picture from our photo shoot back when we were developing transition to care from about 6 or 7 years ago, of just the fact that we have a hospitalist presence around the city, and then our transition of care nurses. So you guys have probably heard of our transition to care nurses. We've expanded our services in the last few years. They cover patients now at Riverside, Dublin, St. Anne's, and East, and the CDUs. They see all of the COPC patients when they come in to reaffirm who their primary care doc is, to answer some basic questions. They're arranging follow-up, so all the appointments set for when the patients leave the hospital, or the transition to care nurse is working on setting up. They've also now recently got the ability to set up tests in the record. And then they're doing follow-up phone calls, not just on our MA patients, but on our COPC patients at 48 to 72 hours. Kathy Cleary helps lead the Transition to Care Nurse initiative, but she just really has an outstanding team. I mean, they are dedicated, they're excited, and they're one of the reasons that we can even attempt to do this stuff. This slide we put up here only because this is, this picture I think is it Mayor, what, six, something like that. This is 6 years old. So this was not something that we started doing for MA or population health. I had no idea even what it meant. We have been doing this and trying to do this. So when Bill talked about COPC kind of getting in the population health business without knowing it for a long time, this was an example. SNF care, this is a list, and I don't think it's inclusive, of facilities in the city where there is a COPC doc. I want to say COPC hospitalist, but there's one of these facilities where there's a COPC doc that covers patients. They're either medical directors or they're not medical directors, but they round their, I want to say, every other day or at least weekly on all the SNF patients there. So as we branch even into SNF care as part of population health, we have a number of facilities that are already covered by our docs. And home care. Where's Larry?
We're closing in on the end here. Home care partners, Dr. Wolf already mentioned these folks: Mount Carmel Home Health Care, Ohio Health Home Care, and Comfort Keepers. So what's our end game? We started with this slide, building the relationships through the continuum of care to impact better outcomes. And I'm going to maybe give you a little example of that. So we have lots of things set up to help take care of these Medicare patients, Medicare Advantage patients in our population health group. The same slide that we had before, but we looked at that kind of as a linear thing, and this really isn't linear. Here's what the continuum of care looks like. And this really kind of represents our company with a whole bunch of different stuff. I'm going to give you a little example here, and I'm going to make this up as I go, so this isn't real. But let me start here. I have a couple, Mr. and Mrs. Jones. Mr. Jones has had a stroke. He's got atrial fibrillation. He's got Parkinson's disease. And I saw him early in the year for his wellness exam, and I did my HCC coding on him, and I realized he has a pretty high risk-adjusted score. So I engaged our care coordinators to help me with him. And they were able to find some community support for certain things he needed at home. And they were checking in on him on a regular basis. And one day they called and said, "Well, Mr. Jones, how are you doing?" He said, "Well, I'm doing pretty good, but my leg hurts. It's kind of red and it's kind of swollen." And but I've got an appointment with Dr. Blosser in about 10 days, so I think I'll be okay. And the care coordinator said, "No, I don't think you'll be okay. That sounds like that needs to be taken care of today." So the care coordinator called my office, and Mr. Jones came in and saw me, and guess what? He had cellulitis in his leg. It was really big, and it really looked worrisome. I ended up leaning on our hospitalist, and he got admitted to our observation unit. And he stayed in our observation unit getting IV antibiotics for a couple of days. At the end of a couple of days, the hospitalist said, He looks pretty good. I just don't think he's ready to go off IV antibiotics yet. So they had the TCN set him up to go to our CDU. And he got 2 more days of IV antibiotics at the CDU, at which time his leg looked a whole lot better. They put him on oral antibiotics, and they sent him home. His wife's a nice lady, too. She's a little frail. She's got osteoporosis. And long about 4:30 one afternoon, she got pretty bad pain in her back. She called the office. We were closing, but she really needed some care that night because she was in a lot of pain and we didn't really know why. So we sent her to the same-day center. Same-day center saw her. They x-rayed her back. And because they're working in the same electronic record that I'm working in, they noticed that she'd had some wedge compressions in her spine before. And because they're using the same radiologist, the radiologist was able to say, you know, that one fracture has progressed. She's got a compression fracture. So they were able to see her and treat her all within the same record, return her to me, and say, hey, she's got osteoporosis and she's got a new compression fracture. Well, we don't even show everything around the continuum here because now I'm going to refer them on to our endocrinologists who are doing a bone clinic and going to see any of our patients with fractures who have osteoporosis and make sure that she's on the right medicine. She's been on a medicine for osteoporosis, but she had a fracture. So obviously something else needs to change. And you know, all of this happened within COPC. We didn't have to send the patient anyplace else. It all happened in one record. We all knew what we were doing. We took care of a patient as a team, and really, we got a better outcome. And I think what those 2 examples would tell you is that we're on the right track for that triple aim of the Affordable Care Act. We increased patient satisfaction because they got taken care of right away and they got taken care of well. We increased the quality because we didn't order unnecessary tests. We didn't expose them to risks by doing things that didn't need to be done, but we did everything that did need to be done. And finally, we lowered the cost of care because we didn't revert to some old habits that we all have, like, oh, your back hurts and it's late in the day, go to the ER. That's not a good solution anymore. We have better ways to take care of folks. Our journey continues. Y'all got to put on your ruby slippers and get ready to go. I'm going to give you my 30-second synopsis of our population health, okay? So here it is. We're going to see our Medicare Advantage patients, Aetna and Medigold, early every year. We want to see them in the first 3 months. We're going to do appropriate HCC coding on them so that we can identify who's the high risk, who's the rising risk, and who falls into that lower risk group. We're going to employ care coordination strategies with our care coordinators for that high risk group. We're going to use PCMH techniques to help identify and manage that rising risk group. And we're going to keep everything within COPC, and we're going to provide the best care for these patients you can get in the city of Columbus. So I hope you are as excited as we are all about this journey. It's something that's brand new. It is something that we are kind of at the front edge of things. There aren't a lot of people who are doing this. As Dr. Wolf says, we're building the airplane as we fly because there really are not plans on how to do this. And we're going to rely on all of you to be helpful, to see things that you think can benefit the program and talk to us, give us feedback, and work with us as we move forward in Medicare Advantage Shared Savings Program. So.